Good afternoon. Thanks for joining me. I am Josh Pedrozo, Vice President of Client Solutions here at Employers Health. Big thank you to everyone for joining us this afternoon. Before we get started, just a couple of items to cover. First of all, you can submit your questions at any time via the Q&A widget on the left-hand side of your console. All attendees are in listen-only mode, so please do use that functionality to get any of your questions, and we will do our best to answer those throughout the presentation. There will be a copy of the presentation available for download. You'll be able to find that by clicking on the paperclip at the bottom of your screen, and you can also look for the recording to arrive in your email sometime tomorrow. Also, upon exiting the webinar, there will be a survey to provide your feedback. We absolutely appreciate you filling out that survey and giving your feedback. It does help us to shape our future content and ensure that we're providing things that are of value to all of you out there. So let's go ahead and get started. Joining us today is Erin Tatar. Erin is Senior Vice President, Head of Consultant Relations at Employer Direct Healthcare. Prior to joining Employer Direct Healthcare, Erin spent 4 years as Senior Vice President at Fidelity Investments and 16 years at Willis Towers Watson. While at Willis Towers Watson, she helped to launch the organization's national healthcare delivery practice, helping evaluators evaluate and implement emerging provider network strategies, including ACOs, COEs, high-performance networks, and delivering reimbursement models. So, Erin, I'll welcome you and allow you to introduce our panelists today.
Great. Thank you so much. And welcome, everyone. Good morning, good afternoon, depending on where you are. I am joined here by my colleague, Ben Sanders, as well as the two folks you're really going to be interested in hearing from, Laura and Derek. I'll let them each introduce themselves. Ben, you want to start?
Yeah. Hey, Ben Sanders. I'm Vice President of Strategy at Employer Direct Healthcare.
Laura?
Yes, I'm Laura Wallace. I'm Director of Total Health for ArcBest.
And Derek?
Hi, I'm Derek Busta, Manager of Benefits for Phillips 66.
We are so appreciative of you all joining us here today. So let's jump in. Pharmacy often rises to the top of the priority list for employers. It's a huge line item, often 20% of spend, that's pretty easily bucketed and identified. There's lots of different stakeholders vying for employer attention with solutions to help manage that spend, but those costs have continue to be pretty difficult to control. Interestingly, surgery costs, which includes MSK-related costs, orthopedic surgeries, but not limited to that by any means, has not historically been managed as a focus area of opportunity historically, the same way that pharmacy costs have been. But interestingly, it often makes up about 20% of spend and is trending at 15% a year. So the great news is there are options for employers to manage those costs, and that's what we're going to talk about today. So Laura, I want to start with you. I know you were seeing ever-rising MSK-related costs in your population. Can you share more about what you were seeing?
Yes, thank you, Erin. So typically, we always saw MSK spend, if not number one, number two in our top categories of cost. And just kind of all over the board, we do have people that are working in our service centers on our docks. So there's a manual labor piece, but then there's also MSK related to sitting at a desk all day and things like that as well, right? So yeah, always in the top spend category for us.
What about you, Derek?
It was the same for us. It was in our top two spend, just behind cancer, obviously a very large category for us. and something that we had seen even in the most recent couple of years, seeing double-digit increases in our overall MSK spend. We had seen 16% in the most recent year over year for 23 over 22. And that is, of course, concerning for us. We've been trying to find ways to tackle that. And I think what also stood out for us, besides the cost, is just how impactful it is, the number of members who actually use or end up incurring a claim across that musculoskeletal category. Neoplasms is big for us, of course, but there are 3 times as many people who were incurring an MSK claim than there were on the cancer side. We're trying to address both, but the breadth of people we had to reach across surgery plus and MSK was very important to us.
I love that framing around just how many people how many lives can we touch? How many people can we help? So surgical costs, especially facility costs, is an area where variation in costs, not necessarily related to quality, is really important. You may have seen a recent RAND study finding and reinforcing earlier RAND findings that employers and private health plans are paying on average 254% of Medicare prices at hospitals. And then, by procedure, we see a ton of variation in cost across the country and even within individual markets. For example, in Boston, the cost for a hip replacement varies between $30,000 and $70,000, depending on the hospital you go to, based on one recent study. Ben, I'm going to take this next question to you. Can you talk about why there is so much variance in cost for the same procedure? I assume it's not because some surgeons and facilities are 3 times better than others and therefore can charge 3 times more?
So I think that's exactly right. Like maybe the short answer is no, I can't tell you why. And that is illuminating in and of itself. If we look at data, there's a study earlier this year that showed variation is there in exactly the way you described it. And they can isolate what's not causing it. Quality is not driving that variation. Cost of living by geography is not driving that variation. And so what that means is factors that shouldn't play into why you would spend more are causing you to spend more. And it's really inconsistent. You can have 2 patients in the same area spending radically different amounts of money or inversely correlated quality. And that's really unacceptable, but it also points that there must be a solution.
Thanks. That's really helpful. And that's actually what we want to get into next is sort of how to think about solutions in this space. I always use a pretty straightforward framework when thinking about healthcare costs. There's 2 components. There's unit cost, what do you pay for the service? And there's utilization, how many of them are you buying? And the good news is that in the surgical space, there are a number of levers that employers can pull to reduce those total costs. I mean, first, there's reducing utilization, the amount of services that are being bought. You can bring in programs like Hinge Health or SWORD that help improve access to PT as a lower acuity alternative. Also, population health programs that, for example, reduce weight, can improve health in general. And if your employees are seeing the right surgeons, you will see a higher rate of surgical avoidance because the best surgeons will really only want to operate on those for whom they're sure they can achieve an optimal outcome. And so that's how a COE can help with that surgical avoidance piece. Another lever is finding ways to reduce surgical complications, which can actually be as high as 15% in areas like bariatric surgery. So again, that's where a COE that steers to a specific surgeon who specializes in a specific procedure and consistently delivers low complication rates can help. But really, the most valuable component from a cost perspective are those unit costs. The hard dollar savings are delivered if you lower the actual cost of the surgery through lower negotiated rates. And this is where some COEs are able to help employers in achieving that. So I'm going to go back to our employer panelists. Laura, when you were looking to address surgical costs, what were the different types of solutions that you were considering?
So I think as we started, just really looking at surgical costs, like you said, avoidance is the first thing that you want to try to do, right? So if you can avoid that surgery and just making sure that people are getting the surgery that they need. And then if it is the surgery they need, that they're getting a top quality provider. But kind of some ways, like you mentioned, that we looked at to reduce maybe people even having to have surgery. So a focus on wellness, and that included programs like Wonder for a mindful eating program, help people lose weight, take that weight off the skeletal frame. We introduced Sword in 2021, and that was great from both a virtual standpoint, people being able to have physical therapy in their home and getting that done, and we actually did help see that lower surgeries. And then the other thing I think that we used is an expert second opinion. So before you go under a knife, using a service like a second MD or something to, encourage members to get that second opinion, and maybe even make that mandatory, if necessary, just to make sure, are you really doing the right thing, at the right time.
Those are all great strategies, and you were already clearly very progressive in how you were thinking about all of this. Derek, what about you?
Yeah, it is very similar as you could expect. We did dive in very heavily on well-being on our end as well, investing in exercise, weight management, education, et cetera, for our employees. We did also deploy Sword Health for the digital PT. That was very important for our remote employees and in a number of those remote locations, but also for our employees in major cities who just simply don't have the time to dedicate to going to a physical therapist to treat their condition. And I think that's the biggest piece for us in our investment on well-being. It is that we're trying to solve a person's problem. Nobody goes in to do a surgery or go see an orthopedist because, they're feeling happy and they just want to see that person. They have pain, they have an issue, they can't do whatever it is that's fun for them, whether it's playing with their kids or it's swimming or playing football, basketball, whatever have you. So we tried to put in programs around them that made it simple for them to get back to doing what they loved. And sometimes it was the other things that were actually causing their musculoskeletal issue. And if we could keep them away from, unfortunately, cut happy surgeons, then we could ideally help them avoid that or find another avenue. Then otherwise, for those who did actually need a surgery, to help them determine what their best course of care was, we did also have our expert medical opinion provider and treatment decision support through Included Health that we made available and continue to communicate very heavily to our employees. And then, of course, for those who are ready to move on to that next step, it was making sure that we had great advocates available to help navigate them to the right providers in their area, and also a great network of providers once they were ready to go ahead and do that procedure. And we did, of course, our broad providers, the Blue Cross Blue Shield and the networks, as well as Surgery Plus to help us to solve that. Those are the big things. And I really would say I would be remiss if I didn't say we didn't forget the basics of making sure that our underlying network was also competitive and cost competitive and comprehensive. That's really important because we don't catch everyone in the COEs.
You both illustrate how the scope of any benefits leaders' responsibilities seems to grow by the day. I also appreciate the fact that you both wove in the need to really think about folks who are in rural locations, because that's something that we're going to come back to. So we're definitely seeing centers of excellence emerge as a primary strategy to address the issues that we've been talking about. According to a recent Pulse of the Purchaser strategy, the most common strategies that employers are using to address healthcare costs are COEs and site of care strategy, which can be embedded into a strong COE solution. And according to the Business Group on Health, 92% of employers have adopted COEs as their primary intervention to address value in healthcare. Most of those, however, are leveraging the centers of excellence that are available through their health plan carrier. And while we're seeing more and more popularity of this as a strategy, we also know that many employers have been frustrated with the results that they have seen. They haven't achieved the engagement rates that they expected. Part of the challenge is an inability in some models to steer to very specific locations and surgeons. Also, historically, some of these models, there was a pretty high expectation for travel, especially those in mid-sized cities or rural areas. And I know we've seen, based on our data, that there is a dramatic reduction in utilization with even a 2-hour drive. And then the other piece is limitations around the number of people that you can help. Many COE solutions are just focused on major musculoskeletal surgeries, bariatric and cardiac, but stop there. And while others are able to reach more people. So Laura, I'll start with you again. When you were looking for a COE solution, what were sort of the foundational requirements in your scorecard as you evaluated solutions? I know the coverage for both rural and urban areas was one of the things that was important to you.
Yes, so we do have service centers in all 50 states, actually. So some of those can be in, more major metropolitan areas, but a lot of them are, just like you said, in those mid-sized cities and locations that may not have top quality facilities, in their area. So I really think, looking at it from an equity standpoint, even, it's not fair that just because you live in one part of the city, one part of the country, you can get better care than somebody else. So, just being able to find who those centers of excellence are. They may not be as far as you think sometimes, but not everybody knows that. So, you only know who you have in your area. And so having a solution through a center of excellence that could kind of help people find what is the best solution, how far do I have to go? And I think that's one of the things that we looked at, is giving people options. So do you want to go to, Mayo or, John Hopkins or somewhere, or would you like to find a center of excellence that's just an hour, that is just an hour away, maybe, or, 2 at the most, but that's close enough to home that you can get back home after the surgery, or your family can be there without a lot of cost and expense. So those things were definitely important to us in looking at centers of excellence. And then the other piece would be what areas. And so just like you were saying, Erin, not just focused on cardiac or MSK even, but, there may be other things. And I know we've used Surgery Plus in a lot of different categories and areas, and that has been really good for our members to have those options.
I love your inclusion of the concept of health equity as a key consideration. I often think about that in the context of travel expectations. The folks, think about who is least likely to be able to travel, to take that time away from work, to step away from their caregiving responsibilities. So I love that. Derek, what about you? What were the kind of key criteria that you were considering as you were evaluating strategies in this area?
Yeah, that equity piece is amazing as well. I completely agree with you all on that. I think that this is great for people, not just on the equity of having to travel. We have a lot of folks in Louisiana who come to Houston, for example, for large care, and for a long time it was just kind of the norm and expected, but we would love for them to not have to go that far. But I think the equity also expands on the economic side too, for people who simply cannot afford perhaps the best surgeon in the area, or the surgeon we may want them to go to. How can we really level the playing field across the the economic spectrum for our employees, that you can get great care with a great surgeon in your area, regardless of how much you make. And that story is extremely powerful. And I think also really does what we intend to do in our Total Rewards program, which is to provide actual value for our employees, something that is tangible to them. That's putting money back in their wallets. That's putting money back in their retirement accounts or for their children or whatever have you. And that's extremely important. But I think more broadly, as we're thinking about COE requirements, yes, that proximity, how many surgeons or sites were available within the geography of where our employees were, was extremely important. The other piece too was, what is the criteria for actually selecting those surgeons? We don't want you to plop as many surgeons as you can around our people just so you meet the geographic requirements. We want to make sure that they are all high quality. So what was the choice? What was your criteria for putting them in the network? And how do you continue to review that and enforce to make sure that when our employees are going, we don't have to worry that there is this missing quality component when they go there for the trade-off on cost. I think that is extremely important. And I know John will attest that I asked a lot of questions about that. So John Zutter, when we were going through this process.
You are a former consultant.
I am. And I think he appreciates the fact or understands that I can't stop asking questions. So I'm glad that he humored me. The other piece too was the member experience. What would members actually experience going through this? Yes, if we could solve the cost, and the cost was important, and we needed to understand how you all came to that determination. But if our members didn't want to use it or wouldn't like using it, they would never come back. They would never recommend it to their colleagues here. So we had to know, well, how will they call? How will they get into finding the right surgeon in your network? Okay, so after they find that surgeon, they'll get there. Then what? Who arranges travel? Who arranges reimbursement? All these other things that go into the actual care experience that is almost just as important in the success of a program than the actual care.
Absolutely. We call them total rewards for a reason, right?
Absolutely.
Right. Yeah. And, you know, I love that tie back to the financial affordability. If you are successful in, you know, successfully reducing costs through a COE, for many employers, that means then there's an opportunity to reduce the cost share responsibility for the member as well, which again, that financial affordability driving health equity piece is so important. So, you know, as Derek and Laura were just speaking to, I'm sure they're not unlike many of you who are listening. They're looking for a solution that would reduce cost, improve access to quality, and it employs needed options close to home. You know, our point of view is that a COE that's actually going to reduce costs needs to meet these criteria. It all starts with quality. There's no one universal definition of quality, and even I would say some of the scoring methodologies that exist are imperfect in their ability to appropriately adjust for risk for a specific patient and the risk burden that's managed by a specific surgeon, for example. As a result, health systems, payers, professional societies, and employers often use their own set of criteria. So it's, again, there's no universal designation you can point to say, that's a high quality facility, that's a high quality surgeon. So when you're talking to a solution, it's really important to look under the hood and understand what kind of framework they're using, what data they're using to define quality. The unit cost reductions that we spoke to are critical. If you have a COE through your carrier, it's almost always negotiated. Basically, it's the same rate that you would pay through your PPO. That and you know, you're not going to see the hard dollar savings that you can get through independent COEs that ideally are actually part of a prospective bundle. So there's some shift of financial risk as well. You're going to want to look at whether or not there are local options based off of the map. For your particular population, as we've mentioned, most folks don't want to travel. In some cases, they can't travel. And we see that corresponding drop with even a drive of 1 to 2 hours. And then finally, it's important to think about which procedures are you going to cover? How inclusive do you want that coverage to be? As Derek was saying, how many lives do you want to be able to touch? So I'm going to actually, next go to my colleague, Ben. When we think about this second point on unit cost reductions, can you talk more about how independent COEs can get better rates compared to the carriers? And we've actually already had a question come in about how bundled payments or episodes of care might fall into this. So it might be good for you to go ahead and address that here as well.
Yeah, look, it's the $1 million question because it's the dynamic that just doesn't make sense. It was actually maybe my third week after starting employer direct healthcare. I sat down with the president of a major health system, and he said, "Look, this is all well and good, but I just don't believe you because we have 10 times the lives you have. You can't get better rates than us." And like that is logical on its face, but the way you end up at better rates is it's fundamentally a different product. The major carriers are creating PPO networks. And as a result, they're contractually restricted from hard steerage. And so they can't provide real volume guarantees to any of their providers. And that in and of itself is how you get discounts. So at a high level, we provide volume because we are a narrow network and we definitionally do steerage. I don't go to a city and say, how do I get 5 fantastic surgeons in this city for a specialty? Or 25 or 50 as the like PPO-based networks might. I go to a city and I say, who are the very best surgeons? And can I get 1 or 2 of them in my network? And if you're going to do that, you're going to be able to guarantee meaningful volume. And that's going to change the dynamic. That's like, if that's the headline, then there's a ton of really interesting pieces beneath it, which I'll just hit on that nuance for a minute because it goes to the bundling piece. There are 3 parts to a surgical bundle as we create them. There's anesthesia, there's facility, and there's the actual surgeon doing the cutting. The reduction that we're taking on any given surgeon or anesthesiologist is minimal. It's a little bit of a reduction. The lion's share is on the facility fee. And that's a fixed asset. And it's also, so if I'm going to someone's ASC, it's a fixed asset. They're happy to take the incremental volume for a reduction. If I'm talking about getting hospital outpatient or inpatient settings for my doctors, that actually opens up a whole kind of prisoner's dilemma of negotiation opportunities because we can start to play different hospitals off each other. As long as I have the right physician and I make sure that the hospitals are good quality, then I can start to really negotiate significant discounts. And then you start to kind of talk about, well, and what benefit are you providing to your doctors that would allow them to take even a minimal reduction? So there's the volume we talked about. We pay orders of magnitude faster than the large carriers do. So they're getting their cash quickly. The members frequently don't have any cost share. So you've got people who are just happier and they attribute that happiness to the provider. And then finally, what I think is really important and it gets lost is the members that we're driving toward our providers are on average more optimized towards surgery. So what I mean by that is they are less likely to be someone who showed up and just didn't need a surgery. That happens. We've got great providers that produce great surgical avoidance rates. But like the other members of this panel talked about, they're frequently gone through something like a hinge or a sword or some sort of second opinion, or they're just further down on their surgical journey. And that means they're, from a total economics perspective, actually more margin accretive, or they make more money for the surgeon. So that's a really dynamic or complex set of nuances that boils down to we provide a lot of volume in a way that no carrier designing a PPO network is actually contractually allowed to do.
You know, as just a brief follow on, because we're actually doing well on time, said, and never before has happened in my life. We're addressing another question that came in. How do you reconcile that promise of volume with a promise to our employer stakeholders around surgical avoidance?
Oh, yeah. So really important. I think surgical avoidance, there are kind of two sides to this coin. The first is we choose the best surgeons. And if you're choosing the best surgeons with the lowest complication rates who do the most of these surgeries, they are cutting on the people who actually need surgery. And that's the only way you get real surgical avoidance, is by choosing the people who are going to do the right surgeries. Like, that's how you enter our network. That's it. Now, how do I then promise these doctors volume in a way that doesn't goose up those numbers and actually delivers as surgical avoidance? Well, when I sit down with a surgeon who might enter our network and I talk about the geography they're in, the number of members we have, and the surgeries they can expect, the kind of conversion from members to surgeries that I'm talking about bakes in an expected surgical avoidance that's best in class. Because my expectation is, if I'm having that conversation with a doctor, I've already reviewed enough of their data, done a site visit, understand who that surgeon is in a way that I can expect a surgical avoidance rate that's going to deliver only the right surgeries to the doctor.
Great. Thank you.
And I think that's actually very important. I'll chime in since we have time too. I got the exact same question from our internal team. Like, okay, you put in a surgical network. Of course, the surgeons will want to do the surgery. What do you mean that you have this contractual part of avoided complications, or avoided surgeries or procedures? And I said, it is incumbent upon Surgery Plus to do that. And as we've talked about the methodology that they go by of selecting the surgeons, and also my expectation that you will track the actual utilization of that, the avoidance of those surgeries, that's how we make sure that happens. But our C-suite is they also didn't believe it or expect that that would be the case. And I think that that's exactly. So being able to put that expectation on Surgery Plus and to see the reporting on the back end, and also tracking that expectation from year to year is big to us, and is a way to continue to show the credibility of the program.
Yeah,
Thank you for adding that.
Maybe if I could try to just bring that to life with a quick picture of one of the surgeons. We have this absolutely fantastic spinal surgeon, went to med school at Harvard Medical School, did her fellowship at the Hospital for Special Surgery, and has been not only featured in many articles and a co-author in many articles, but actually has designed and hold patents on many of the things used in surgeries across America today. That's the type of person that's in our network, that kind of the leaders in their field. Those people are not wanting for surgical volume, and they're not spending their time operating on people who shouldn't get surgeries. But you need to have surgeon-specific selection down to doctors like that doctor.
Great example. So we thought it would be helpful to really quickly sort of boil down the types of questions we would recommend employers ask as they're thinking about whether or not a particular COE type solution is going to deliver the types of results that Derek and Laura have seen, which they're going to talk about in some case studies here in a minute. If you have a COE through your carrier, we would suggest you ask, are they steering to specific surgeons, sort of at the individual procedure level within the facilities that they have designated as centers of excellence? What, if any, reduction in underlying rates do you get when your members use those carrier COEs? How much utilization are they seeing through those COE facilities and surgeons versus out in the community? And what has been, for you as an employer, the downstream impact on both quality and cost? If instead you're looking at the universe of independent centers of excellence, again, we would suggest you really look under the hood to understand what are the qualifications at that individual surgeon level that they have in place to be invited to participate in the COE network. What does that network look like? How far will your employees have to travel? What are the plan design recommendations that are encouraged or almost, required in order to get a high level of utilization. And at the end of the day, I personally think what matters most is how many people did they actually help in your key markets? How many procedures did they perform by independent surgical type in the last 12 months? So sort of with that in mind, Derek, I'll start with you. Any other suggestions for the types of questions that benefit leaders should be asking as they think about looking at these types of solutions?
Yeah, absolutely. I think going to the biggest one first, obviously the savings piece. Yes, the reduction in rates is important, but I think the question of the reduction from what is equally important. I mean, what is your reference point? Don't give me a reduction on a national average. I need a reduction on a geographically appropriate amount. You were talking even earlier in the presentation about some of the variations in costs from state to state and so forth. Obviously, if I'm comparing something in Louisiana versus something in New York or New York City, yes, the cost will be different. So I want to know for a fact that the savings for the contract that they have is a reduction on the rate or an appropriate rate in that given geography. And I also want to see data that supports that. I've asked the Surgery Plus team that question many times, and they have thankfully obliged and given me that information. But I have seen some very weird math in my career on calculating savings. So it is great to verify. I think staying on that same point around the savings piece, we all have to pay for these programs. So how the company would actually contract? Is it a PEPM? Is it a percentage of savings? Is it a percentage of actual savings on the procedure? Or are there a percentage of savings on other items like avoided care or avoided complications, et cetera? I think that contracting piece is important when you talk about building out a program. We all think of it, but there's some very novel ways that many of these COEs, whether it be with the carrier or outside of the carriers, do contract. And it's good to go in with both eyes wide open. Beyond that, the member piece, I talked about that quite a bit. The member satisfaction, what are they seeing? What are the member surveys coming out of their product? Do they have an NPS score? Do they track that? Do they have other member surveys? Where can we get feedback on how the actual patients have perceived the entirety of the process? I think that one's very big. And then, yes, the markets, where are they expanding? Where are they contracting? Just understanding the dynamic of that, because like many other large employers, we've got a broad footprint, but we're also growing in different areas, and we want to make sure we're with a partner who can grow with us as we do.
I love your comment about weird math as a recovering actuary. Laura, while we've seen a real surge in interest over the last 12, 18 months, you were really more of an early adopter. I believe you implemented Surgery Plus back in 2022. Way back then, in 2021, 2020, whenever you first sort of started that journey, do you have any additional suggestions for benefits leaders? What were you thinking about at the time when maybe the framework around evaluation wasn't as mature as it is today?
So, Erin, a couple of things, I'll echo what Derek said as far as member experience. That's very important to us. And, how is our employee going to find that person? We actually uniquely serve as our own TPA. So we are very close to the data, very close to our employees, our internal customers, as we refer to them. So their whole experience is important to us and making that an easier solution for them. But the other piece that I would say a little bit different is how is this COE going to interact with our other solutions? And it's very important to us, one, that they're a cultural fit for us, that they, and we have truly not chosen some vendors because they just did not fit from a cultural perspective, didn't align on values or, things like that. So those things are important to us. But then, how are they going to interact with our other partners? So we did already have an expert second opinion in place when we chose the Center of Excellence, and, you know, had a great relationship with them. It had great experience. And so it was important that that relationship, so if somebody goes and gets an expert second opinion and the opinion is, yes, I think you do need to have surgery, then this just became a natural progression to refer them into a place to get the best surgery from the best person. And vice versa. So if somebody goes and says, I think I need to have surgery, and they're talking to Surgery Plus, and the recommendation is, no, I really don't think you need that now. But did you know that ArcBest offers SWORD, you know, and it's an opportunity for you to do physical therapy at home, and, you know, they can set you up on that. So just that interaction with your other vendor partners, I think, is really important for us.
I love that you highlighted the importance of that vendor integration piece, not only from a member experience perspective, but also as a real opportunity to enhance utilization of the program. Well, next we're going to go into some more specific case studies from Laura and Derek to briefly set the stage. Given not all of you may be familiar with us as an organization, Employer Direct Healthcare provides access to high quality care, the highest quality care, for over 5 million members and 350 clients today. We have two products, Surgery Plus and Cancer Care Direct. And today we're really focused on Surgery Plus, where we're providing concierge support to guide members to individually selected surgeons with a core focus on local access for all plannable procedures. Our prospective bundles are contracted at 50% or less of carrier costs, and at the end of the day, that delivers on average $15 per employee per month, or in many cases a lot more, for 100% voluntary programs. So programs that are really viewed as a win-win for both the member and the employer. So starting with ArcBest, Laura, can you talk us through your experience and some of the impact you've seen since launching with us back in 2022?
Yes. So just kind of to start, I think we talked at the beginning about how MSK was a number one or number two cost for us in 22. And then while it was the number one cost, we did continue to see that cost come down. So with the implementation of first SWORD in 21 and then Surgery Plus in 22, we have seen that MSK classification of costs go down to about half of what it was actually in 21. So our projected cost for 24 is a 50% decrease in MSK cost, and it is now coming in at about number 5 in our diagnostic category. So, so that is one thing that we have really seen. We have seen more people doing bariatric procedures, and so that's a benefit for them. They have found that. It's definitely something we work to kind of help make sure they are learning how to eat right. You know, Wonder is a qualification to be able to have bariatric surgery. So just those two things kind of going together to make that a successful surgery. So not just that they're getting it done at the best place, but what other care are they getting before and after. So again, back to that vendor partnership, that's really important. So it's been very good. It's been used locally and then in other locations, which is what we would hope for people that maybe are having trouble finding a good local provider.
That's a great overview. I'm curious, I mean, any feedback on how members have received the program, or you know, stories that you hear internally?
Yes. So I think the biggest thing that our members have really liked, and this kind of goes back to even the questions that you might ask, is how that process works. But the concierge piece, really, that Surgery Plus has for our members is just so helpful, because you can tell people you have a Centers of Excellence program, and if you just send them to a place to then search for a provider, you're probably not going to get them there. But when the response is just call this number to start this process, that is so much easier for them to be partnered with somebody on the Surgery Plus team, a care coordinator that is helping them through that whole process, whether it's helping to get records to the right place, what are the, who are the providers that they need to talk to, if they need to travel, coordinating all of that for them is just so important. And then they're not having to pay, a cost for that either. So we've got a lot of really good response back on just the way the care coordinators have helped people through that whole process.
That's great. So Derek, you went live with us more recently for 2023, but would love to hear what your experience has felt like.
Yeah, absolutely. It's been a great experience so far. We launched in actually late 2023. It's a bit of a long story, but we had a great relationship with Surgery Plus in the past from a joint venture that had Surgery Plus, and our joint venture, we actually ended up purchasing them and bringing them into Phillips 66 Company, and that's when we started to evaluate to expand to our broader population, which occurred in September. So we had a bit of a head start. That joint venture was relatively small, but there was a great experience that they had there. But we have had tremendous financial and employee experience success since that came online just under a year ago. $2.3 million in total savings is tremendous for us to have in our program. I think one of the bigger successes as well, kind of piggybacking off of Laura, honestly, is the member experience. Those who are able to go and say, look, I just take care of my deductible. That's the way we set it up. We said, pay your deductible and everything else is covered from there. And members like that simplicity of being able to just pay one amount, one known amount, and not worry about the myriad of bills that come afterwards. The anesthesiologists who are notorious for throwing out an invoice in December, like, God, I did that 10 months ago. Where did this come from? Folks just don't want to have to worry about it. And they love that this experience is different, that they have the care coordinators, that they have the ID card in their wallet that's mailed out to them, something that they can really know, all right, if I call this number, I can get what I need done and taken care of, and they can steer me from there. That high touch piece is generally is difficult to achieve across healthcare in many places without a big cost. So being able to do it here is a win-win for us.
That's great. Thank you both for sharing your stories. I'd like to end the formal presentation with sort of a fun question. For both organizations, you sort of had found new money as you shrunk the cost of the pie, as you reduced overall healthcare costs. Laura, how, based off of priorities within ArcBest, how have you thought about reinvesting those savings? How have you used that sort of new money?
So I think the biggest thing for us is if we can maintain healthcare costs or reduce healthcare costs, then we're going to share that savings back with the employees and their premiums, whether it's reduced premiums or maybe, some other benefits in other places as well. So, whether it's increased vacation time, caregiver leave, or, just some of those other benefits and other ways that we can use that money. But we really try to keep our employees' cost low. So whether it's, keeping the deductible low, keeping healthcare premiums down, those are the things that are really important to us.
That's great. Derek, what about you?
Yeah, same here. That's always the first place we go is, can we reduce or hold as close to flat the employee premiums for enrolling in the plans every year? And then also, can we just not have to increase a deductible, a copay, a coinsurance? We try to stay away from those things, and having programs like this to generate savings really allows us to do that. We've done a good number of things over the past few years that have generated savings for us, and where we have invested historically, and where I think we're going to continue to as we continue to rack up the goods here with programs like Surgery Plus. Well-being is important to us. We have invested in financial well-being for our employees. So free financial coaching that we rolled out a couple of years ago, and we recently expanded here about a year or so ago. We have also invested in a number of smaller programs that are really for overall employee health for them. So sleep health across anxiety health, across the overall digital counseling and other things that we're able to easily get approval for. Could we have gotten approval for it? Probably, because they're good solutions by themselves. But when we're coming in with something where we have savings, it's just a much easier conversation to say, hey, look, we did this and it's budget neutral because we're saving from this other program. It just brings far more fluidity to our conversations with our executive team.
A lot easier, yes, absolutely.
Yes, absolutely.
Well, thank you both. We've had several questions come in, so we'll address those. Ben, I'm going to put you on notice that I'm going to send this first question your way. How do we calculate savings? You're the 1.8 million for ArcBest, the 2.3 million for P66. Is that based on an average cost? Is it the actual underlying network discount if the claim had not gone through Surgery Plus? Just can you share a little bit more about how we put a point on that?
Yes, really, really important. It is not an average. It is not national. The way we do this is we say we have two numbers that are really important. Every single dollar you paid to Surgery Plus for that procedure. Okay, so that's known. That's exactly relevant to the member in question.
Our contracted rate, right? Yeah.
Our contracted rate, exactly. The second is, what would you have paid for that member if that member had gone through your commercial carrier? And that's the tough one to know. And so what we have to do is make sure that when we're quoting it, we're hitting a few things. One, I'm being conservative in my construction, so I'm not overselling you on it. The second is that it is actually relevant to that member. So there I mean the correct procedure type and not a really broad categories of lots of different kinds of procedures that would fall into that. Like, for instance, I don't want to make it joints and include thumbs as well as like total knee replacements. Those are two very different costing things. But the second is, this is a little bit less relevant to our program where you're more likely to stay local, but is still built into it. If I'm going to take you across the country, put you on a plane and put you somewhere else, let's say I'm going to take you to New York for a procedure because it just is the right place for the hyper specialized procedure you're getting. When I quote you what you would have spent, I'm going to quote you what you would have spent where the member lives, not where we took the member to. And I think that's really, really important when you're creating that savings construction. It's like, that's my little monologue on how we think about savings. It's specific to the member. It's specific to the geography. It's specific to where the member would have had the procedure prior. But then maybe simply they were just asking, that's just procedure savings that you're looking at in that 1.8 million.
That's really helpful. Thank you. I'm going to ask you another question, but then I'm going to ask Derek and Laura about their experience, what they've heard from members. We're a narrow network. We're driving more volume. Does that mean that the surgeons in the Surgery Plus network have extensive waiting times?
Good. Really important question from a member experience perspective. Short answer, no. Longer answer is average waiting time for an appointment is approximately 10 days. We don't usually achieve that through contracts stipulating amount of days seen, but instead the fact that we have very good relationships with these providers. The providers know to look out for us. And then we have kind of concierge treatment on the back end that are also the same level of concierge treatment that the member is getting, we have teams of people who work day in and day out with our provider groups to make sure that our members are being seen, they're being seen by the right physician, they're getting scheduled in the right facility, and that's happening quickly.
Laura and Derek, is that consistent with your experience, the feedback you've heard from your members?
I would say I haven't heard anything about people having to wait, long times and I think part of that, is maybe it's perception because they're talking to their care coordinator on a regular basis. And I think that's just really important, is that there's somebody that is talking to them through that process. And so if there is a wait time, they know what the wait is and kind of what's going on through that time.
Yeah, I agree. I mean, the wait times, I have not heard anything bad about the wait times either. And I hear about wait times often. It is one of the reasons why we put in programs and advocates and things like this, because I hear so much about it across healthcare, how long it takes to get into a good quality place. And so for the fact that I have not heard it about Surgery Plus means that it's going just fine. And also, I think the reality is if they had to wait, they would go elsewhere. As much as if it were too long, as much of a good financial deal it is and the good experience and everything else, they are trying to solve an issue. They have a pain, they have a problem, they have something that they need done, and they simply wouldn't wait that long if they had other options.
Thanks for that. I want the record to reflect that you guys did not know that I was going to ask that question, so I can breathe now. One last question, I think, that we have time for, that, again, I'm going to ask Derek and Laura to respond, and if we have time, I might have Ben weigh in. We have a lot of other priorities at my company. Why should we prioritize a program like this right now? Laura, you want to go first?
I can. So I think for us, everything is about making sure that our members are getting the right care at the right time. And so if that means they have to have a surgery, we want to make sure they're getting that done at the right place. And I mean, surgeries, like you said, can be expensive, and it's all those little different pieces. It's, the hospital costs, the surgeon costs, the anesthesia costs, and just helping them to be able to budget, whether that's, copay waived. And then you don't have to have a repeat surgery either, because you're getting into the best provider at the best care. And you don't have, complications or anything like that. So speaking from somebody who did not me personally, but a case that did not go to Surgery Plus, that we are paying highly for. I wish more people would do that. So,
What about you, Derek? What would you say to an employer who's asking why they should prioritize something like this amidst all the other requests they get from employees and leaders from a benefits perspective?
Absolutely. I think it goes back to the very beginning of the conversation, which is one, if your priority, as it is for many other employers, is addressing your top cost drivers, then you have to address musculoskeletal costs. And this is, if you go look at your data, surgical portion of MSK is going to be one of your largest components of your musculoskeletal costs. So this is a way to address one of the largest components of your 1, 2, or number 3 largest diagnostic category in your claim spend, period. It is huge. So if cost is not your thing, congratulations. But if you're looking for something else that can address a broad number of people, again, getting back to just how many people are impacted by musculoskeletal claims. You're talking children playing football, soccer injuries, falling out of a tree, or the person who's running with the wrong shoes, all the different things that can lead to an MSK injury, and the number of people you could help and get back to better is really important here. And I think that this is a good overall member experience to help them solve whatever that problem is. So that's the other benefit of it, if cost isn't your number one. Or maybe those are both important to you. You can solve both.
That's great. Thank you. I think that's a great way to wrap things up. If we didn't get to your question, we'll connect with you directly. Thanks so much to our presenters, especially, but also all of you who took the time out of your busy day to attend. And we hope you have a great rest of your day.